Welcome to Cardiology Section 6. Follow with us as we review cardiomyopathy.
All right, so the three types of cardiomyopathy, we got dilated, hypertrophic, and restrictive. Dilated, we're talking about systolic heart failure. Hypertrophic, we're talking about diastolic heart failure. And then restrictive, we'll talk about that. So dilated cardiomyopathies, we've just talked about in the last presentation systolic heart failure. So dilated really is systolic heart failure. So we talked about it primarily being somebody who has a heart attack, but there are a lot of things that cause dilated cardiomyopathies. Ischemia being our number one cause, heart attack, cocaine, and arrhythmias can lead to a dilated cardiomyopathy. Hepatitis C is the most common cause of dilated cardiomyopathy due to a virus. Alcohol is a toxin and it causes dilated cardiomyopathy. The important thing about alcohol, however, is if it's stopped early enough, a dilated cardiomyopathy, once the alcohol is stopped, can return to a completely normal heart. So it's the one that's reversible. Chemotherapy can also lead to a dilated cardiomyopathy. There are several of those that will require the patient to get an echo prior to actually getting the chemotherapy. Genetic, when they put HOCM here, hypertrophic cardiomyopathy, all muscles that get big eventually get small. They overdilate, the walls break down, and then they deflate. So hypertrophic cardiomyopathy eventually will lead to a dilated cardiomyopathy. My best example, I think of just, Arnold Schwarzenegger when he was very young. He was very big, muscles were huge, and if you see him now, he's kind of deflated. And that's kind of like HOCM when he was younger, and now he's dilated cardiomyopathy as he's gotten older. No disrespect, I love Arnold. Takotsubo, this is a dilated cardiomyopathy that's a reversible. On its own, it's a transient epinephrine release, and this causes a dilated cardiomyopathy that after a week or two actually will go back on its own. So the treatment for dilated cardiomyopathy, we've already talked about systolic heart failure. All of these here, if they lead to a low ejection fraction and they lead to this S3 heart sound and a dilated cardiomyopathy, you just treat them like the systolic heart failure. Beta blocker, loop diuretic, and ACE inhibitor for the chronic treatments. And if they go into acute treatments, stop the beta blocker, add the nitrate, push oxygen, double your diuretic and put it IV, and keep the ACE inhibitor. So go back to that systolic heart failure section and look at that one where the four guys are there, and just look at the two at the end, and you know the difference between chronic and acute. Hypertrophic cardiomyopathy, this is generally in young kids. This one's important. They like to ask a lot of questions here. It's a genetic mutation of the sarcomere. You don't know when the mutation is going to trigger. So the kid may be 14 years old when he finally develops hypertrophic cardiomyopathy. He may be 17-year-old when it finally develops. So the best example would be a young kid. He comes in, he has a hypertrophic cardiomyopathy. He's 15 years old and he has a little brother. So anybody who has hypertrophic cardiomyopathy, you must screen the family, any first relatives, to see if they have it as well. So he happens to have a little brother, so now we're going to screen him with ultrasound and examination every year until we see when he has the hypertrophic cardiomyopathy. So he had it at 15, his little brother at 13, we check him, nothing. We check him at 14, echo looks good, exam's normal. Check him at 15, echo is normal, exam looks good. Check him at 16, exam is good, looks normal. Check him at 17, suddenly he now has the the hypertrophic cardiomyopathy developing. So you don't know when it's going to happen, but you have to screen and you follow them serially as they get older. So hypertrophic cardiomyopathy looks just like aortic stenosis. They have the same three symptoms, angina, syncope, and heart failure. Because they have the hypertrophic cardiomyopathy, that's why they get the S4 heart sound. They have the thick, stiff ventricle, and they're going to have an apical lift. It is the most common cause of sudden cardiac death in young kids. So the signs, apical lift, S4 gallop, and they'll have an ejection murmur medial to the apex. This will not radiate to the carotids. The important thing about this murmur here is that what you can do is a Valsalva maneuver, or you can have them squat and then stand up, and it actually has a paradoxical or an opposite effect of what it would do to an adult murmur. So with hypertrophic cardiomyopathy, if you have them squat, if they had a murmur, it would actually diminish, and when they stand up rapidly, the murmur would actually get louder. Whereas somebody who has a cardiac adult murmur, if you had them squat, the murmur they had would get louder, and if they stood up, the murmur would diminish. So they get the opposite effect. So hypertrophic cardiomyopathy, if they have a murmur, Valsalva, the murmur will diminish as they squat and get louder as they stand. The echo will show LVH. And the treatment for hypertrophic cardiomyopathy, sometimes we use diuretics. The mainstay of treatment is going to be the beta blockers or the calcium channel blockers. The calcium channel blocker being number one because it's going to be blocking the extra calcium in this thick ventricle, allowing it to relax. We do surgery in selective cases. They can either do open heart or septal ablation. Open heart is more invasive but has better outcomes, less complications. Septal ablation is for patients who are a higher rate of complication risk due to comorbidities. They can't be intubated, whatever the case may be, but it has a higher complication rate. Remember to screen family members of everybody with hypertrophic cardiomyopathy. That is the genetic mutation at the sarcomere, and it doesn't just happen at like age 14 or 15. You have to follow them until it finally develops. Here's an example of hypertrophic cardiomyopathy. Here's the normal heart. And then you can see here, this is the big thick septum, and the ventricular wall here on the left side is really, really thick. Because of this, what happens is the structure of the ventricle is changed. Normally this here closes and the blood shoots out the aorta. Instead, the blood will actually shoot out through the mitral valve before it starts going out the aorta. So they often have a severe mitral regurgitation associated. Restrictive cardiomyopathy, you got to think of it as diastolic heart failure. They have S4 and a thick, stiff ventricle. What happens in restrictive cardiomyopathy is they get a deposition into or between the heart cells. So amyloidosis, somebody who has hemochromatosis, sarcoid, scleroderma, fibrosis, or cancer. Any of these gets extra tissue in between the cells of the heart, causing it to become stiff and not squeeze very well. So restrictive cardiomyopathy is just a diastolic heart failure, and you treat the underlying disorder and or transplant. So you're looking for any of these is going to lead to the diastolic heart failure, the S4, and transplant and treat the underlying condition. Constrictive, think of a boa constrictor. Think of the pericardium as a boa constrictor, a big snake around the heart. So constrictive cardiomyopathy is the pericardial sac is affected and it constricts the heart due to scarring. So somebody who gets frequent episodes of pericarditis can get this, somebody who gets radiation, tuberculosis. These are all reasons why the pericardium can get scarred. Then it becomes constricting and it squeezes the heart. So what happens in constrictive cardiomyopathy is they'll get fatigue, dyspnea, body swelling, and it looks like right heart failure. The reason it looks like right heart failure is the right ventricle is the weakest out of the two ventricles. The left pushes 120/70, the right normally pushes only 15/5 pressures into the lungs, so it's usually the weakest on the right side. So when you have the pericardium squeezing the heart together, the ventricle that's going to fail first is the right side, and so that's why they look like they have elevated jugular venous pressure or the JVD. They end up with fluid backing up into the right heart system or into the liver, and they get the peripheral edema. So constrictive cardiomyopathy, they're going to have JVD, fluid in the liver, maybe fluid in the legs, and the treatment is just pericardial stripping. You're going to be looking for a history of either radiation, tuberculosis, recurrent pericarditis. They're going to present with right heart failure, clear lungs, but all the right side, JVD, liver, and leg swelling.